Today, we're tackling a topic that, well, it affects everyone at some point, but we're going to go far beyond just simple remedies. We're diving deep into the surprisingly complicated science that keeps your gut working, exploring the sophisticated pharmacology governing the entire gastrointestinal tract.
It's one of those things where people think about GI issues like, constipation or diarrhea, and they think it's all purely mechanical.
Right, something's just or moving too fast.
Exactly, but the stack of sources you brought in, it really reveals a field of pharmacology that's governed by this delicate cellular signaling, ion pumps, and even immune modulation.
So we're not just talking about symptoms.
No, not at all. We're examining a system that's in a constant state of balancing fluid movement and chemical signals.
Exactly. So our mission today is to unpack this entire spectrum of GI drug therapies. We want to go past the name on the bottle and really explore the precise biochemical levers that these drugs are pulling. We'll cover everything from, the gentlest laxatives and life-saving rehydration solutions to the real heavy hitters, the immune-suppressing biologics for chronic conditions.
And this is where it gets really interesting for anyone trying to learn this stuff. To treat these common conditions, we have to intervene directly in the movement of ions, sodium, potassium, chloride,
And the flow of water.
and the flow of water right across those intestinal cell membranes. So whether the problem is too slow or too fast, the solution almost always lies in manipulating fundamental cellular biology.
We'll be looking deep into the structure and function of the small intestines, villus cells, and the colon's crypt cells.
That's where all the action is.
That sounds like a true deep dive.
Okay.
Okay, let's unpack this starting where most people start, when the system slows down. We need to look at the drugs for constipation, but the terminology can be confusing.
It can be.
So let's start by defining what the source material actually means by these different degrees of action.
Right, because the drugs we use to promote the elimination of feces, they're categorized almost entirely on how forceful they are.
Okay.
And that distinction, it might seem a bit academic, but it really helps us understand the goal of the treatment.
So on the milder end of the spectrum, for routine maintenance or when we just want a little bit of help, what term should we be using?
There we use the term laxative or a slightly older term, aperient.
Aperient.
Yeah, and this implies a gentle action. The result you're looking for is the elimination of soft, usually formed stool.
So this is for typical functional constipation.
Exactly. It's about increasing frequency and just improving consistency.
But if we need to cleanse the bowel entirely, maybe before a medical procedure or in a case of a really serious blockage, we need something much more aggressive.
Precisely. And that's when the drugs get called purgatives or cathartics.
Okay, purgatives.
Those words indicate a much stronger, more forceful action. You're often going to get a voluminous, fluid, or even watery evacuation. The goal is to clear the entire system.
Okay, help me understand the overlap here, because the source material notes that this distinction is often, a bit vague. It says many drugs act as laxatives in low doses and purgatives in high doses.
It is, yeah.
Is it really just a difference in the dosage?
It is, largely. I mean, take a drug like a magnesium salt.
Right.
If you take a small amount, the osmotic action might just soften the stool. That's a laxative effect.
Right.
But if you take a large concentrated dose, the massive osmotic pull of water into the lumen creates such a high volume and pressure that it forces this strong, rapid fluid evacuation.
And that's the purgative effect.
That's the purgative. The underlying mechanism of osmosis, it's the same. It's just the degree of the effect that changes dramatically with the dose.
So it's the difference between gently turning up the water pressure and, opening a fire hydrant.
That's a perfect analogy.
So regardless of the degree, the fundamental goal is the same. Increase the water content of the feces and promote propulsion. Our source material outlines 3 primary routes to get there, all revolving around fluid dynamics.
The first route is the most intuitive one. It's osmotic or hydrophilic action.
Okay.
This involves putting a substance into the intestinal lumen that the body just can't absorb. And because water follows solute,
Right.
these substances, whether they're large ions like magnesium or complex sugars like lactulose, they just hold water and electrolytes in the gut.
And that increase in trapped water, it acts mechanically then.
Yes. By increasing the volume of the colonic contents, you're increasing the intraluminal pressure, which naturally stimulates the colon's walls to contract and push everything forward.
It's just simple hydraulics.
It is. The sheer bulk promotes propulsion because the system interprets that increased volume as a signal to, get moving.
Okay, so mechanism 1 is basically brute forcing the pipe to fill up. The second mechanism, as it's listed in the sources, is less about drawing water in and more about stopping the body from taking water out.
That's a great way to put it.
Yeah.
The second mechanism is characterized by acting on the intestinal mucosa to decrease water and electrolyte absorption. So if the epithelial cells lining the intestine can't efficiently pump sodium or chloride out of the lumen back into the blood, well then the water that follows those ions has to stay put.
Which softens the stool.
Exactly.
And the third mechanism is direct stimulation, increased propulsion, which you mentioned is often a secondary effect.
Right. While the stimulants definitely increase motility on their own, the overall increase in propulsion is often the combined result of the first two mechanisms.
How so?
Well, if more fluid stays in the lumen, the material just moves faster, which allows less time for the remaining water to be reabsorbed. It's kind of a cascading effect.
Let's dedicate some serious time to the cellular mechanisms behind the stimulant purgatives, because this is where the biochemistry really gets interesting.
It does.
These drugs are not gentle. It sounds like they launch a molecular attack on the body's natural systems.
They are powerful, and their action is multifaceted. They often target the cells responsible for absorption, the villus cells, and simultaneously turbocharge the cells responsible for secretion, the Crypt cells.
Okay, so let's start with that first critical action. The inhibition of the sodium-potassium ATPase of villus cells. For our listener, can you detail why disrupting this one single enzyme is so fundamental to how we absorb fluid?
Absolutely. The sodium-potassium ATPase is one of the most vital cellular components in the entire body. It's a pump embedded in the basolateral membrane of the villus cells.
So the side facing the blood.
The side facing the blood, exactly. And its job is to constantly pump sodium ions out of the cell and potassium ions in. This maintains a very low internal sodium concentration.
And that low concentration creates a gradient.
It creates the electrochemical gradient. That's the driving force that allows sodium and other molecules coupled to it, like glucose, to be absorbed from the gut lumen into the cell. And water, it just passively follows this massive sodium movement.
So if the stimulant drug inhibits that pump, if it basically flips the off switch on the sodium pump, what happens?
The gradient collapses. Sodium is no longer efficiently swept out of the cell, so sodium absorption from the lumen just stops.
Grinds to a halt.
It does. And since water absorption is completely dependent on sodium reabsorption, the water stays trapped in the lumen. You've essentially closed the biggest tap in the reabsorption system.
And at the same time, they're turning on the fluid secretion taps in the Crypt cells.
Yes. Stimulants also work by stimulating adenyl cyclase in Crypt cells. Adenyl cyclase is an enzyme that synthesizes a critical intracellular signaling molecule, cyclic AMP or CANAP.
And high levels of KMP act as a signal.
A very strong signal.
Wow.
It opens the chloride ion channels, the floodgates, on the apical surface of those Crypt cells.
Chloride ions rush out, and water follows the rush.
Precisely. This results in a massive secretion of chloride, bicarbonate, and water into the intestinal lumen. So the drug is simultaneously stopping absorption and promoting secretion.
Wow.
And on top of that, these stimulants can enhance prostaglandin synthesis in the mucosa, which is another potent way to increase secretion. Some sources even suggest they can cause microscopic structural injury to the mucosal cells themselves, which further impairs absorption.
These are highly specific molecular weapons against intestinal fluid retention.
They really are.
Okay, understanding that complex science, let's look at the categories. Starting with the safest and generally the most recommended first-line approach, bulk-forming agents.
These are the foundation. We are talking about unabsorbable natural dietary fiber. Cellulose, lignans, gums, and things like psyllium or isfagula and methylcellulose.
It's essentially just roughage, but used medicinally.
That's right. When they hit the gut, they absorb water, they swell, and they form this soft, gelatinous mass.
And that dramatically increases the intraluminal volume.
Right, which stimulates the stretch receptors in the colon wall and promotes the natural wave of peristalsis. They are often the gentlest, and they usually take 1 to 3 days to achieve their full effect.
I noticed something a little counterintuitive here that we should probably explain. Why would a drug used for constipation also be prescribed for chronic diarrhea, like in irritable bowel syndrome or diverticulosis?
It's a great question, and it highlights that the goal is regulating consistency, not just movement.
Okay.
In certain types of chronic diarrhea, the stool is watery and poorly formed. By taking a bulk-forming agent, you actually increase the viscosity and the water absorption capacity of the intestinal contents.
So you're making it more solid.
You're creating a more homogeneous, bulky consistency, which can stabilize the bowel function in those suffering from chronic diarrhea or IBS.
What's the crucial drawback we need to hammer home regarding how to use these properly?
The absolute necessity of adequate fluid intake.
Right.
If you take a dry psyllium product and you don't drink enough water, the fiber begins to swell immediately. And that can potentially lead to impaction high up in the GI tract, even esophageal obstruction.
So you're basically pouring cement mix without the water.
That's a good way to think about it. It can set too fast. It's a key safety warning.
Next up, let's explore the stool softeners, the drugs that act more like emulsifiers or lubricants to ease passage.
Here we find the docusits, or DONS, which are anionic detergents. Their job is to lower the surface tension of the fecal matter.
Like dish soap.
Very much like dish soap. The detergent allows water and fat to penetrate into the dense feces, emulsifying the contents and softening the mass, which makes it much easier to pass.
Yeah.
They typically work over 1 to 3 days.
Then we have liquid paraffin, or mineral oil. This is a non-absorbable viscous petroleum hydrocarbon. It's an old remedy, but the sources are just loaded with warnings about it.
The warnings surrounding liquid paraffin are significant, and you really need to understand them fully before ever considering its use. While it acts effectively as a lubricant,
Sliding the feces along.
the risks, they often outweigh the benefits.
What is the primary, most severe risk?
Lipoid pneumonitis. This happens if the oil is accidentally aspirated, even tiny droplets, into the lungs. It's especially common in bedridden, elderly, or debilitated patients.
And the lungs can't clear it.
No, because as an oil, the lungs can't clear it. It causes the severe chronic fat-filled inflammation and damage. It's a potentially fatal outcome, which is why it's used so sparingly in a clinical setting today.
And then chronic use introduces another problem, nutrient absorption interference.
Yes. Since it's lipid-based, chronic use can interfere with the absorption of fat-soluble vitamins, A, D, E, and K.
So deficiency becomes a real problem over time.
It can. Furthermore, its lubricating action means it can leak through the anal sphincter, which causes discomfort and can interfere with healing. The consensus is really use it only occasionally and with extreme caution.
Okay, let's turn to osmotic purgatives. These are generally much faster, relying on these non-absorbable substances to create a massive pull of water into the lumen.
This is a powerful, reliable mechanism. We see 2 main types, saline purgatives and disaccharides. The saline group includes magnesium salts like sulfate and hydroxide, and sodium salts like phosphate and tartrate.
And their non-absorbable ions just dramatically increase the osmotic pressure.
They do. And I recall the source mentioning that magnesium salts have a secondary action beyond just simple osmosis.
Oh, right.
In addition to the osmotic pull, magnesium ions are also known to trigger the release of cholecystokinin, or CCK.
And that's a hormone.
It's a hormone that augments GI motility and secretion. So you get the water influx and stimulation of the movement.
These saline purgatives, they're used when you need a rapid, aggressive cleanse, right?
Absolutely. They are the go-to for rapid bowel prep before procedures like surgery or a colonoscopy. They often clear the system within 1 to 3 hours.
But that speed and power must come with a massive safety caveat.
It does. Systemic side effects if absorbed in patients with compromised kidney or heart function.
Okay, walk us through that crucial warning. Why are these high-salt formulas contraindicated in patients with renal insufficiency or congestive heart failure?
Well, even though the primary goal is to keep the salts in the lumen, some absorption inevitably occurs.
Right.
If a patient has impaired renal function, they can't efficiently excrete that absorbed sodium or magnesium. The excess sodium retention leads to fluid overload, which exacerbates CHF, and can even cause pulmonary edema.
And the magnesium.
Excess magnesium can lead to systemic toxicity, causing muscle weakness or cardiac issues. This is why saline purgatives are never prescribed lightly and require very careful patient screening.
This leads us to the specialized category of disaccharide osmotics, lactulose and lactitol. These are semi-synthetic sugars, and their most fascinating use goes way beyond routine constipation.
Lactulose is a beautiful example of using the body's own ecosystem, the colonic bacteria, for drug activation and treatment.
So as a disaccharide, it isn't absorbed in the small intestine.
Correct. When it reaches the colon, the bacteria ferment it, breaking it down into smaller, highly osmotic products like lactic acid and acetic acid. This draws water in, making it a mild, effective laxative.
But the real insight, the thing that makes this drug so clinically vital, is its use in hepatic encephalopathy. This involves chemically trapping a toxin. How does that acidic breakdown of lactulose do that?
Right. So hepatic encephalopathy is a severe complication of liver failure, where the body can't properly process protein metabolism waste products, specifically ammonia. NH3, yes. This toxic ammonia builds up in the blood. It crosses the blood-brain barrier, and it impairs neurological function.
So we need to get rid of the ammonia before it gets to the brain.
Exactly. When lactulose is broken down by the colonic bacteria, the resulting lactic acid drastically lowers the pH of the colon, making it much more acidic.
Okay.
And this low pH environment performs a chemical conversion. It drives the reaction that converts gaseous, freely absorbed ammonia, NH3, into the much larger, non-absorbable ammonium ion, NH4 plus treg.
It's literally trapping the toxin in the gut.
It is. The ammonium ion is trapped by its charge, and it cannot cross the intestinal wall back into the bloodstream. It's then safely excreted in the feces
So it reduces plasma ammonia concentration.
by up to 50%, and it reverses the encephalopathy. The laxative effect in this case is just the required mechanism to move that trapped ammonium out of the body. It's an incredibly smart application of chemistry.
Finally, we move to the stimulant purgatives, the drugs that forcefully initiate movement. We already discussed their complex cellular actions, but let's look at the specific drugs themselves.
Yeah, this group includes bisacodyl, sodium picosulfate, the diphenylmethanes, and the anthraquinones like senna. They are known for their reliable, sometimes aggressive action.
Tell me more about bisacodyl. It's a classic example of a pro-drug in this category.
Right, so bisacodyl and sodium picosulfate are given orally. They're inactive in the stomach and the small intestine. They have to travel unchanged all the way to the colon,
Well, the enzymes are.
where the colonic enzymes, sometimes bacterial but often mucosal, cleave off the acetyl groups. That's a deacetylation. Only then is the active, highly irritating drug released, which directly stimulates the enteric neurons and kicks off all those mechanisms we detailed earlier.
And because it depends on travel time and activation, it takes a while to work.
It takes 6 to 12 hours for an oral dose to work.
And the plant-derived anthraquinones.
Senna and cascara are metabolized by colonic bacteria into active anthrols, or amidins. They're reliable, and they come with that notable, though generally benign, side effect, melanosis coli.
That sounds alarming, pigmentation of the colon mucosa.
It does. It causes a darkening of the mucosal lining, usually brown or black patches, from pigment accumulating in macrophages, but it's usually considered harmless, and it's entirely reversible once the drug is stopped.
It just shows the impact these drugs have on the gut lining itself.
It does.
So given their power, the biggest safety warning for stimulants involves prolonged or chronic use.
The risk is substantial. Regular use of potent stimulants can cause severe fluid and electrolyte imbalance, particularly leading to dangerously low potassium levels or hypokalemia.
And the most severe long-term consequence.
The cathartic colon structural injury to the neural and muscular components of the colon, essentially paralyzing it and leading to reduced function and even reliance on the drugs.
So they're also contraindicated during pregnancy.
Absolutely, because the severe pelvic congestion they can cause might trigger premature labor, and they're absolutely contraindicated in cases of diagnosed or suspected intestinal obstruction.
Okay, so we use these drugs for acute transient constipation, chronic functional constipation, and specialized tasks like bowel prep or managing hepatic encephalopathy.
Yes, and crucially for specific patient groups, like bedridden patients recovering from a stroke or a heart attack, where straining has to be avoided.
Or for patients on chronic opioid therapy. Speaking of opioids, the treatment for opioid-induced constipation requires a highly specialized drug, methylmaltodexone.
This is a wonderful example of targeted drug design. Opioids cause constipation by activating the new opioid receptors located in the enteric nervous system of the gut wall.
Okay.
Methylmaltodexone is an opioid antagonist, but it has been specifically engineered with quaternary ammonium structure.
Which makes it highly polar. Why does that matter?
Because it means it cannot cross the blood-brain barrier. It acts like a highly specialized lockpicker, engaging and blocking the mu receptors only in the gut wall, which reverses the constipating effect.
But it leaves the central pain relief intact.
Crucially, it leaves the mu receptors in the central nervous system untouched, meaning the patient retains the essential pain relief from their opioid. It's a targeted peripheral intervention that avoids central consequences.
That brings us to the end of the slow movement. We've explored how we slow down absorption and speed up transit. But now let's pivot hard to the opposite extreme, the crisis of fluid loss that defines severe diarrhea.
Right.
Diarrhea is clinically defined by the WHO as passing 3 or more loose or watery stools in 24 hours. And its global impact is just tragic. Our source material reminds us it still causes the death of about 1,400 young children every day worldwide.
And the danger isn't the symptom itself, it's the massive fluid and electrolyte loss that leads to hypovolemic shock.
And the root cause at the cellular level is a complete imbalance in the absorption and secretion machinery. So we need to look at those two cell types again: villus cells and crypt cells.
In the healthy small intestine, the villus cells, those finger-like projections, are the absorbers. They're primarily transporting sodium, glucose, and water back into the body.
And the crypt cells.
The crypt cells at the base of the projections are minor secretors. They push out some chloride and bicarbonate. Normally, absorption dominates.
What flips that switch, turning the system into a floodgate?
Pathological states, particularly bacterial toxins, toxins from E. coli or the notorious cholera bacterium, bind to receptors on the crypt cells.
Okay.
This binding causes a massive uncontrolled increase in intracellular levels of cyclic nucleotides, specifically cyclic AMP and cyclic GMP.
So KMP is the biological alarm signal that triggers the crisis.
It's the key trigger. When KMP levels spike, it activates protein kinase A, which in turn opens the primary chloride secretion channel on the apical membrane of the crypt cells.
And this causes a massive efflux of chloride ions.
A massive efflux, which establishes a negative charge in the lumen. To maintain neutrality and osmotic balance, sodium, potassium, and huge volumes of water rapidly pour out of the cell and into the lumen.
So the crypt cells become high-speed water cannons, and at the same time, the villus cell's normal absorptive power is inhibited by some of these same toxins.
The result is just pure, unrelenting outflow, leading to severe volume depletion, acid-base disturbances, and electrolyte chaos. That is the pathophysiology of secretory diarrhea.
Given that deadly fluid loss, rehydration is the priority above all else. For moderate loss, we turn to oral rehydration therapy, or ORT. This is often called the simplest medical miracle of the 20th century.
It really is. The development of ORT is arguably one of the most successful and cost-effective public health interventions ever. Before ORT became widespread, children dying of cholera often required expensive, complicated, and often inaccessible intravenous hydration. ORT allowed caregivers to treat severe dehydration at home or in basic clinics using a simple, cheap powder. It transformed the management of diarrheal disease and saved millions of lives.
And the reason it works, the core science, is its ability to bypass the toxin's effect entirely, relying on one specific persistent mechanism.
Yes, that is the crucial insight. The sodium-glucose cotransporter in the villus cells remains functional, even when the toxins have maximally stimulated the crypt cells to secrete.
The body has a backup system that the toxins can't disable.
It does. Help us visualize that cotransport. How does coupling sodium to glucose overcome the pathological secretion?
So the sodium-glucose cotransporter, SGLT1, it works like a revolving door. It will only bring a sodium ion into the cell if a glucose molecule is attached.
And this process is independent of the CAMP-driven secretion mechanism.
So when you provide water, sodium, and glucose in the oral rehydration solution, the glucose forces the continued active absorption of sodium.
And as sodium enters the villus cells, it creates the osmotic gradient necessary for water to follow it passively from the lumen back into the bloodstream. It overrides the crisis.
Let's review the WHO formula composition. Because to maximize this cotransport, the composition of the ORS is meticulously balanced.
The formula composition is critical. The current standard, which is the low osmolarity formula, is set at 245 ml/ml.
Okay.
It contains balanced amounts of sodium, chloride, potassium citrate, and, crucially, glucose. The 1-to-1 ratio of sodium to glucose is key to maximizing that coupled transport.
Why the emphasis on the newer ORS formulas? The older formula was slightly hypertonic, around 310 ml/ml. What did the low osmolarity formula achieve?
The old formula, being slightly hypertonic, could sometimes actually exacerbate diarrhea by drawing water out if absorption wasn't instantaneous.
Oh, wow.
The 2002 WHO low osmolarity formula proved significantly better. Clinical trials demonstrated it reduces stool volume and vomiting by about 30% compared to the older formula, making it safer and more effective, especially in young children.
Beyond fluid, we have the micronutrient angle, zinc supplementation. This has become a major part of management.
This is a key recent finding. Giving zinc typically 10 to 20 milligrams a day for 10 to 14 days significantly reduces the duration and severity of acute diarrhea in children under 5.
And it's an easy, cheap intervention.
Very. And it yields substantial results. Zinc appears to have multiple benefits. It directly reduces fluid secretion in the gut, and it also improves the gut's immune function and dramatically aids in the regeneration and repair of the intestinal epithelium, helping the gut wall recover faster.
So once rehydration is prioritized, we look at medication. The first decision is whether to use antimicrobials.
And the simple answer for most acute diarrhea is often no.
Right.
Most acute non-inflammatory diarrhea is viral or caused by non-invasive bacteria, so it's self-limiting. Antibiotics are unnecessary and can sometimes be harmful, leading to resistance, or in the case of salmonella, prolonging the carrier state.
So when do we bring out the heavy artillery?
We use them only for specific, confirmed invasive or inflammatory diarrhea. For example, severe Shigella infections, high-risk traveler's diarrhea, or Clostridium difficile.
For traveler's diarrhea, you'd use ciprofloxacin.
Often, yes. And for C. difficile, which causes a severe antibiotic-associated colitis metronidazole, or oral vancomycin, are the drugs of choice.
We also have rifaximin, which is highly specialized because it works where it's needed but doesn't get absorbed into the rest of the body.
Rifaximin is fascinating. It's a rifamycin derivative, but it is minimally absorbed. Less than 0.4% enters systemic circulation.
Which means it concentrates its antibiotic activity entirely in the GI lumen.
Exactly. It strikes the gut pathogens without causing systemic side effects or resistance in the rest of the body. It's highly tolerable.
Now, for the non-specific antidiarrheal drugs designed purely for symptom control, slowing the system down, the most common are the antimotility drugs, primarily loperamide.
Loperamide is a synthetic opioid analog, but it is engineered to be a peripheral actor. It works by activating the mu-opioid receptors, located exclusively in the enteric nervous system.
So it increases smooth muscle tone and reduces the propulsive waves. It just stops the movement.
It does, and the key advantage is its safety profile regarding dependence. Unlike codeine, which can cause central nervous system effects, loperamide is actively pumped out of the brain. At therapeutic doses, it acts only on the gut.
But we have to deliver the critical safety warning again. These drugs are strictly contraindicated in specific types of invasive diarrhea. We need to go into detail about why this is a life-saving warning.
This is a non-negotiable safety point. If a patient has inflammatory invasive diarrhea caused by toxins from organisms like Shigella, you must not use loperamide.
Because decreasing motility slows down gut clearance.
And if you slow down transit, you keep the toxins and invasive bacteria in prolonged contact with the inflamed, permeable intestinal wall. This dramatically increases the time available for systemic toxin absorption.
Potentially leading to septicemia.
Or, in severe cases, triggering toxic megacolon, where the colon distends dangerously, risking rupture and death. Symptom relief is not worth that risk.
That distinction between non-invasive and invasive diarrhea is everything.
It truly is. If there's blood or fever, the answer must be antimicrobials or antisecretory drugs, not antimotility agents.
Speaking of antisecretory drugs, the sources introduce racecadotril as a promising agent that seems to provide the benefits of an opioid without the motility risks.
Racecadotril is a beautiful piece of targeted pharmacology. It's a prodrug that works by inhibiting the enzyme enkephalinase.
Enkephalinase.
Right, and that enzyme normally degrades our body's natural opioid peptides, called enkephalins.
So it's a preservation mechanism.
Yes. By protecting the endogenous enkephalins, racecadotril allows them to naturally activate the delta opioid receptors in the gut. And activation of these delta receptors reduces the hypersecretion of water and electrolytes.
What's the massive advantage this provides over loperamide?
Racecadotril blocks the hypersecretion of fluid, the main problem. But it does not significantly affect normal propulsive motility.
So you stop the flood without causing the dangerous stasis.
A secretion block without a motility penalty, exactly. It makes it a safer option for acute watery diarrhea, and it's frequently used in children because of its favorable profile.
And finally, we have the simple adsorbents like kaolin and pectin.
These are substances that just absorb water, increasing store consistency. They work much like bulk-forming laxatives, but their effect is generally mild and nonspecific, less effective than the more targeted drugs.
We've covered acute swings in GI function. Now, we must turn to the chronic, relentless conditions where the problem isn't a bacterial toxin or poor diet, but the body's own immune system. Inflammatory bowel disease.
IBD encompasses chronic, relapsing inflammatory conditions of the GI tract, ulcerative colitis, and Crohn's disease. These are serious, debilitating conditions believed to stem from a dysregulated immune response.
Just to quickly define the two, ulcerative colitis involves continuous inflammation, typically confined to the mucosa of the rectum and colon.
While Crohn's disease is more destructive, it's characterized by patchy transmural inflammation, meaning it affects all layers of the bowel wall and can occur anywhere from the mouth to the anus.
And the goal of therapy is achieving and maintaining long-term remission.
To prevent irreversible tissue damage.
The foundational approach, especially for mild to moderate UC, involves 5 aminosalicylic acid compounds. The active ingredient, mesalazine, is a topical anti-inflammatory.
Yes, mesalazine is an effective anti-inflammatory agent. But, just as we discussed with laxatives, delivery is the biggest pharmacological hurdle.
Because if you take mesalazine orally in its pure form, it's mostly absorbed high up in the small intestine before it ever reaches the inflamed colon.
Exactly. So drug designers had to figure out how to chemically protect the drug and release it only upon arrival at the inflammation site. This brings us to sulfasalazine, the oldest prodrug.
And this is where the chemistry of the azo bond comes in. Explain the genius of this delivery mechanism.
Sulfasalazine links the active 5-ASA molecule to an inert carrier, a sulfapyridine molecule, using a chemical bridge called an azo bond.
An N double bond N.
Right. And this bond is extremely stable in the stomach and the small intestine, so it prevents premature absorption.
But that stability breaks down once it reaches the colon.
Correct. The colon is rich in anaerobic bacteria that possess the necessary enzymes, ACE reductases, to cleave that azo bond.
So when the bond is broken, active 5-ASA is released directly into the inflamed colon.
And the sulfapyridine carrier is released separately. The body's own microbiome is the delayed release mechanism.
It's brilliant, but the critique points out that the major drawback is rooted entirely in that carrier molecule.
That's the trade-off. While the 5-ASA stays topical, the sulfapyridine carrier is highly absorbed systemically. And this high systemic exposure causes dose-related side effects in up to 40% of patients.
What are the primary side effects that make this drug difficult to tolerate?
Common issues are fever, rash, nausea, headache. More seriously, it can cause bone marrow depression. Clinically, 2 other critical issues are its interference with folate absorption, requiring supplementation, and its potential to cause reversible male infertility.
Which is a significant discussion point for patients.
A very significant one.
To solve that systemic side effect profile, pharmaceutical companies developed newer 5-ASA formulations that eliminated the toxic sulfapyridine carrier.
This is the era of pure mesalazine delivery. Instead of the chemical bond, we rely on sophisticated pharmaceutical engineering special coatings, for example, that only dissolve when the pH exceeds 7.
The pH of the distal small intestine and colon.
Exactly. Or other prodrugs like ulsalazine, which links 2 5-ASA molecules together. The consistent innovation here is ensuring high concentration of the active drug topically in the colon while minimizing systemic exposure and side effects.
When 5-ASA compounds fail or the disease flares violently, we escalate to the heavy hitters, starting with corticosteroids. These are the emergency response team.
They are the fastest way to quell severe inflammation. Corticosteroids like prednisolone are incredibly potent for inducing remission in acute flares of both UC and CRD.
Detail the mechanism. How do they act so rapidly?
They act through both genomic and non-genomic pathways. Their main effect is binding to intracellular receptors, and the resulting complex travels to the nucleus, where it suppresses the transcription of dozens of pro-inflammatory genes.
But that power carries a very high price, prohibiting their use for long-term maintenance.
Absolutely. The list of chronic severe side effects is why they are typically used only for short courses and then aggressively tapered off. Long-term steroid use leads to severe issues like bone density loss, metabolic disturbances, psychological effects.
They're a crisis tool only.
A crisis tool. For true long-term modulation, we must move to the immunosuppressants.
The mainstays are azathioprine and its active metabolite, 6-mercaptopurine.
These are purine antimetabolites. They work by interfering with DNA synthesis, primarily affecting rapidly dividing immune cells like T lymphocytes. This suppresses the immune response that drives IBD.
The source highlighted a crucial clinical detail. Patients initiating therapy must undergo genetic testing for TPMT. Why is this mandatory before starting azathioprine?
This is a critical safety checkpoint. TPMT is the enzyme responsible for metabolizing azathioprine. About 10% of the population has reduced TPMT activity, and a small number genetically lack the enzyme entirely.
And if they lack the enzyme and receive a standard dose...
Without TPMT, the drug can't be broken down safely. The active metabolites build up to toxic levels, causing life-threatening severe bone marrow toxicity.
Destroying blood cells.
Right. The genetic test identifies these patients, allowing clinicians to either drastically reduce the dose or choose a different medication entirely.
Beyond those, we have methotrexate. Where does this fit in?
Methotrexate is a dihydrofolate reductase inhibitor. It suppresses inflammation by interfering with cellular proliferation and also by suppressing inflammatory cytokine production, particularly TNF-alpha. It's a second-line maintenance drug, particularly effective in Crohn's disease.
And finally, cyclosporine. This is a last resort drug.
One of the most potent immunosuppressants available. Its use in IBD is very specific. For severe ulcerative colitis patients who have failed to respond to high-dose steroids.
So it's a short-term bridge therapy?
A temporary measure to buy time until slower-acting drugs can reach their full effect. It's not used for long-term maintenance due to its significant renal toxicity.
That brings us to the pinnacle of current IBD therapy, the biologics. These are genetically engineered protein molecules that target specific steps in the immune cascade, starting with infliximab.
Infliximab is a chimeric part human, part mouse monoclonal antibody that specifically targets and binds to tumor necrosis factor alpha, or TNF-alpha.
And TNF-alpha is a primary inflammatory cytokine that fuels the chronic inflammation.
It is. So this is truly therapy at the molecular level. Neutralizing a key inflammatory messenger is reserved for the most severe refractory cases.
Particularly for Crohn's with complicated manifestations like fistulizing disease.
Yes, where the inflammation is so deep it creates tunnels between organs.
As a large protein molecule, how is it administered and what are the major risks associated with shutting down a central immune cytokine like TNF-alpha?
It must be administered via intravenous infusion, typically every 2 to 8 weeks. And the risks are twofold. First, infusion reactions. Second, and much more serious, is the generalized lowering of resistance to infections.
By blocking TNF-alpha, you impair the body's ability to wall off certain latent infections.
Most notably, tuberculosis. Patients must be rigorously screened for latent TB before starting anti-TNF therapy.
So another mandatory screening, just like with TPMT.
Absolutely. It reflects the delicate balance.
Sure.
You have to suppress the damaging autoimmune response without completely compromising the body's essential defense systems.
This deep dive has truly laid bare the complexity of managing the GI tract. We went from tweaking the hydraulics of the bowel to molecularly suppressing the immune system.
The key synthesis here is understanding that GI pharmacology is defined by two major strategic themes. One, the management of acute fluid crises using precise ion balance regulation. And two, the long-term struggle against chronic inflammatory states, which requires these highly localized delivery systems and massive immune modulation.
We saw the critical importance of drug delivery, how pharmaceutical scientists use the azo bond to exploit colonic bacteria to release anti-inflammatory drugs topically.
Or how methylnaltrexone was designed to be peripherally restricted, ensuring a drug acts only where we need it.
And we learned that the biggest warnings often stem from the drug's fundamental mechanism. The risk of fluid overload with saline purgatives, the danger of loperamide in invasive diarrhea,
And the non-negotiable requirement of TPMT genetic testing before starting azathioprine. These aren't trivial footnotes, they are life-saving warnings derived directly from cellular chemistry.
If we connect this to the bigger picture, the discussion consistently highlighted how resilient and crucial the sodium-glucose cotransport system is. It is a fundamental cellular mechanism that persists even when the entire GI tract is under severe pathological attack from cholera toxins.
It's the body's essential failsafe.
It is.
And this persistence raises a compelling question for future science. If we understand how the body maintains that basic cellular absorption mechanism under such duress, could that knowledge be extrapolated
to other diseases?
Could understanding these fundamental, persistent transport mechanisms unlock future therapies for other secretory illnesses beyond the GI tract, exploiting those basic stable pathways to override pathological states in other organs?
It's a powerful idea of biological stability in the face of chaos, a perfect provocative thought to end the deep dive exploring the resilience of the human cell. Thank you for guiding us through the surprisingly complex world of GI pharmacology.
My pleasure.
And thank you for joining us on the deep dive. We'll be back next time with another stack of sources and another chance to get well-informed fast.